Hi everyone, welcome to today's episode on how audio is reshaping the way that physicians learn and stay up to date. I've got my co-host today, Jonathan, and we'll be going through a GMed white paper that was recently done about how physicians are learning with new audio techniques. So let's dive right into it, Jonathan.
Thanks for having me here, April. My name is Jonathan Sackier. I trained as a surgeon in Britain, and I've divided my time between the United States and the United Kingdom. Although I've been in academic practice, I've also been in private practice, looking after patients, but teaching, training other physicians. And I think one of the things about being a doctor is our dedication to lifelong learning. And as we do that, we have to learn how to learn, and we have to learn how to teach. You know, you don't just become a teacher and you don't just become a learner. You have to learn how to learn. So I'm fascinated to have this conversation with you, April.
Absolutely. I mean, we're going to be basing our conversation on a recent GMed white paper. It's titled Audio in Medicine, How Physicians Are Using Audio Content to Stay Informed. Obviously, this is a very new way of learning. And so let's get right into it.
Well, actually, you say it's a new way of learning, but I would contend that it's actually the oldest way of learning. It predates the written word. I'm going to be going to Spain some point soon, and I've always wanted to go and visit that cave in northern Spain where there are the very first cave paintings.
Yeah.
But before people were painting on cave walls, they were sitting around the fire telling stories of the hunt, stories of how they managed to capture the animal, or how they learned that you don't eat fruit from this tree, but you do from that. They're teaching, right? They're sharing stories.
Right.
And that was the oral to oral tradition. So I would contend that it's an old form. You and I learnt medicine by going, what did we do? Yes, we read books, but we went to lectures. And I would contend that if you ask any doctor listening in to list 5 lectures or 5 lecturers who influenced them during their training, or 5 papers or books they read, they will have no problem with number 1, but they'll have a problem with number 2. It's a very different way of learning, right? Different way of learning.
That's really interesting that you say that, because obviously we start out as medical students. We went to lectures which were more visual and audio. And then slowly as we get into the job, it's an apprenticeship profession. And so it's more kinetic. You're a surgeon, so you learned by doing. And we're almost going back to the audio parts of it. And obviously it's all these different learning styles that we need to cater to. We can't just read journals. So, okay, that's great for the visual learners. But it's very exciting that we have all these different styles of learning that caters to the people who learn in different ways.
Yeah, I think one of the things, April, is there is a tendency nowadays to want magic solutions.
Yeah.
Everyone wants a quick and easy fix. Truth of the matter is, and I know people listening or watching will find this very hard to believe, you and I are different, right? We're biologically different. We have different ethnic backgrounds. We have different life experiences. We are different ages.
Yeah.
All those things play into how we learned to learn. And I have like the 3 C's, because there isn't one fix. There isn't like, are books good? Are audio tapes good?
Right.
That's, the new revolution in learning was a cassette tape you put into your car stereo or into your Sony Walkman. That dates me, doesn't it? But there's no one type of learning. And I say that it depends on the character. We're individuals and we learn differently. I normally cannot do a conference call seated. I have to walk. If I'm seated, my brain just stops working. I don't think it works that well anyway. But so character is important. The second is complexity. What are we teaching? If it's something incredibly complex that needs lots of graphs and, formulas and whatever, or you're teaching histology, difficult to teach histology without images, right? You can describe what you see, but it's much easier to put, there's an H&E stain and it shows such and such. And the third is the context. in which the learning occurs. What point of your career, what time of the day, are you learning the information because you've got a patient in the emergency room and you need help? So character, complexity, context, those things matter.
That's really interesting that you talk about context, because obviously we learn there's the learning that we do in the clinical setting that we learn from our patients, but then there's the reinforcement that happens afterwards. And sometimes, a lot of people do that sort of in their downtime or when they're sitting in the car. So for example, in the white paper, I think there was a quote there. It said one of the physicians, it was quoting one of the physicians who had participated in a discussion on GMED, and they said that they use their podcast during their morning commute. It's the only time that they have to truly focus on broader issues in medicine without being pulled into clinical tasks. And so, this type of audio learning is the reinforcement that needs to happen, and it's the context, and then it's the reinforcement as well.
So yes, doctors. I think, look, first of all, it's important to say that we've got a bit of a perfect storm. There's a growing population. The world population is growing. Britain is said to grow by another 5 million people over the next 5 years.
Wow.
And so we've already got a physician shortage. We've got, medicine is much more complex today, and it's getting ever more complex. And administrative tasks are expanding. So it's a perfect storm. So we have to be better at using our time. I will say, however, that if you talk to physicians across the generations, the French phrase, plus ça change, plus ça même chose, as much as things change, they remain the same. The challenges that we face are actually not new. My big concern, yes, listen, a lot of journals, a lot of platforms are now using audio material to supplement. But there's a very well-known brand of athletic shoe, and their catchphrase is "just do it." Well, I don't think that's a great idea in medicine. I think we need to just do it, but make sure you've got the data to justify it. So, changing from one platform to another just because we think we should, we should have oral, we should do this, we should do that. Again, characters, complexity, context. What's the right form of delivering information? And yes, listen, here's an easy one. You're on your morning commute, you're in your motor car, and you decide you want to exercise your brain a little bit. Should you A, read a book, or B, listen to an audio while you're driving your motor car? So you probably shouldn't read a book.
Yeah.
But actually, should you be listening to information that takes your mind off of driving your motor car? I think we need to look at the context, and we need to have data to ascertain what's the best way of doing it for that character, for that complexity, for that context, and then we'll do the right thing.
That's really interesting you mentioned that as well, because obviously you mentioned journals as a way of, listening, of receiving audio content, audio information. But obviously we've got all these other methods now, podcasts, audio discussions that we can actually listen to. And, listening to journals is great, but it's a one-way kind of thing. It's, when you do learning, it's just receiving that information as it is. There's not a lot of bearing as to how we can implement certain guidelines or certain studies, whether they're applicable or not. And so even listening to people talk about discussions is much more practical and is much more, it helps us more in terms of clinical practice. The other thing that you mentioned is the morning commute, obviously the dreaded morning commute. And I think, because doctors work in different hospitals and have to be in specific specialties, they're types of people that have long commutes. I think a recent AMA survey, there was a recent AMA survey that was done that said that 3 out of 4 doctors drive to work rather than sitting on trains. Obviously, sitting on trains, you can read a book, but in the car, you would have to listen to something because, as you say, you can't drive and read at the same time.
So I just want to pick up on a few things. And again, my position on all of this is don't just do it based on fact. So I fly aeroplanes as an avocation. And if I am taxiing and listening to air traffic control giving me a clearance instruction and I'm noting things down and reading things back, or I'm flying, I'm not listening to a podcast. I'm focused on flying. It's mindfulness. And I would contend, everyone talks today about multitasking. I'm multitasking. I'm driving to work, I'm listening to a podcast, I'm doing such and such, I'm listening to an audio book, whatever it might be. I dispute it. I dispute the brain's ability to incorporate information in a meaningful manner. Because I think what's actually happening, and there's some very good data on the current gen. I always forget, is it Gen Z? Is it Gen, who the hell knows? But, we multitask. And I've seen it with my own son, who I'm having a conversation with him and he's looking at his phone and he's doing 5 other things. And here's what I hear a lot. Huh?
Right.
Huh? Because you're not listening to what I'm saying. You're probably not paying much attention to what you're looking at on your phone, and you're not mindful. As a surgeon, if you're operating, you are mindfully concentrating on that one thing, and there's nothing else in your head. And I would question whether learning is truly taking place, or is it just white noise? And I know that Gen Z, within 5 years, are going to represent, 75% of the workforce. So we better make darn sure that we are adopting methodologies to teach. Now, it may be people have attention spans of gnats, truth be told. Right. I was always taught 45 minutes of dedicated learning, then stop, go for a walk. Maybe we need to think about what message we're delivering, how we're delivering it, who we're delivering it to, when we're delivering it. Again, character, context, complexity.
Right.
So that's important.
It's good that you mentioned methodology because I know you have a great method. Do you want to tell the audience a bit about it?
Well, perhaps first of all, I'd love to get into how, because, the assumption is audio is better.
Right.
Well, again, character, complexity, context. Written information has pros and cons. Audio information has pros and cons. Written information, pros, it allows for deeper reflection and repeated review and referencing. If you're listening to a podcast or an audio thing, people aren't justifying every statement with reference 1. And you can look at the appended information on this podcast in the show notes and you can see the reference. They don't do that. When you're doing an audio, you don't abbreviate.
Right.
It's very bad form to abbreviate. So you come from Britain, right? NHS. We know what the NHS is. I would contend that there are huge numbers of doctors around the world who have no idea what the NHS is out of context. They may if they read something. So written presentations are better for complex detail, heavy information, guidelines, data tables. Written information facilitates note-taking and annotation. Written presentation is generally preferred for independent study and long-term reference. But the cons, it's time-consuming and it can be less engaging if not brilliantly written. And unfortunately, journal publications have to conform to a format. And my goodness gracious me, it can be boring as hell. Oral presentations are passive.
Right.
But if something is passive, how engaged are you? Is the sound just washing over you? I read before I go to sleep at night, but a lot of people will say they listen to something because they find if the voice is mellifluous, if it's monotonous, it helps them fall asleep. Well, that's not ideal. So if it's an oral presentation, it has to be good for high-level overviews, big picture thinking, and it should be provocative. It should be provocative. It should poke you. And I'd love to come on a little later to the 10 points that I learned from Professor Les Blumgart at the Hammersmith Hospital, bless him, many years ago. He was a tough man, but my goodness, what a great teacher. And he taught us how to present. And if we weren't presenting according to his format at the Friday afternoon rounds, and he would sit there with a switch, and that switch, if he flipped it, would turn off the slide projector, turn on the room lights, and you knew that you were going to be having a private one-on-one conversation with the professor, and it was not going to be a nice experience.
Right.
So, oral presentations are good for high-level overviews, big picture thinking. They're useful for engaging storytelling. Storytelling, which is, again, thinking back to the fireside chats.
So I wanted to touch upon this because, speaking of high level thinking, in a recent poll that was done on GMed, I think asking the participants what type of audio content they liked to consume, 44.7% said that they preferred the broader medical topics. And as you say, the data tables and things like that are less relevant. And indeed, I think 22% were listening to audio content only to deepen their specialty expertise. And so exactly like you said, it's the broader things that is more interesting for them, and rightly so, because if you're doing something else, you want the broader ideas, you want to be able to brainstorm, you want to hear discussions, you don't want to get into statistics, you don't want to get into numbers, things that you essentially have to focus and concentrate on.
Yeah, to go back, to take what you're saying and to flesh it out in the context of my comparison of oral versus written,
right.
I would contend, again, character, complexity, context. Mm-hmm. If you read a journal article, and there's some very good data years ago, I'm blanking where it was published, as to how doctors consume journal articles, and it turns out I'm pretty bog standard. I look at the titles and I think, does that interest me? I look at the authors, do I like them or do I disagree with many of their opinions? And people read the abstracts and then they react either, yes, this reinforces my worldview, or B, it challenges my worldview. And if it's one or the other, am I motivated to engage with the author? Well, the old-fashioned way of doing that is writing a letter to the editor. Mm-hmm. And that can take months to get published. Now, can you imagine having a conversation? If you and I had a conversation, if you say something and I just sit here and there's dead air, right, and an hour later I respond to your question, that's not a conversation.
Right.
So I'd suggest that in addition to my 3 C's, that there's another one, and I'll have to try and think of a C for it, which is blended learning, right? So when you do have audio content, if you provoke the audience, so provocation is brilliant, right? The best journalists on television are not the ones who just blindly read the news. They're the ones who say something provocative because it engages the human emotions and psyche. Blended learning. So you have audio content and it says, at the end, we're going to be asking you to participate in a CME quiz, or we're going to ask for your opinion, or we're going to ask you to send your cases, because that engages you. We're having a human interaction. And in fact, there's some evidence-based insights that suggest this is based in fact. Doctors retain more information when oral presentations are supplemented with written summaries or slides, especially in postgraduate and continuing medical education, not so much for undergraduate.
Absolutely, absolutely. And of course, which goes back to physicians being able to just go on GMed and then have a further discussion about whatever the information was given. And thinking about my medical school years, I went to medical school, I graduated in 2016, but that was when we first started problem-based learning. And that's exactly what we did. We read the information, but then we had to go away to learn it, and then we presented it back to each other and had discussions about it. And actually, that reflects what actually happens in clinical life. You see the case, you do it by yourself, But then, of course, you go away. You say, you meet your colleagues in the break room, and you say, you'll never guess what happened to me. And then you go through the case step by step with your colleagues.
Absolutely, that's the case. And that's one of the parameters of storytelling. You
Yeah.
make it germane to the audience you're talking to. You know, there was a quote in the study that you referenced that medical podcasts are an essential tool. I can listen to the latest oncology updates.
Yes.
Or here's one: audio helps me stay informed without needing to carve out time for reading. Again, I'm a little bit unsure about that. I think that if you're listening, then are you mindfully driving your motor car or going for a run? When I go for a run, or if I go for a walk I love going long distance hiking, and I say, oh yeah, I listen to podcasts. Well, I don't listen to podcasts then. I might have some soft music in the background, but frankly, I want to hear the wind in the trees. I want to hear the sound of the river. That's actually good for the soul. Our problem as physicians is not that we're not busy enough. We're too busy. And, whilst I think burnout is a real thing, I don't think we should overbake it. We are very, very fortunate human beings to be involved in the best profession in the world. It's a privileged place.
That's really interesting that you say that, because I wonder if it is sort of context dependent as well, in the sense that, so when I do my morning commute, I go through a bit it's got a lot of traffic, and for that I absolutely do not want to listen to a very in-depth podcast. I don't want data, I don't want anything like that. But then I go through a long stretch of highway that has absolutely no traffic, and it's just very mindless, sort of, straight forward driving. And for that, I actually do enjoy, the audio learning, the stuff that goes into greater depth audioly, because I have no other way to stimulate my brain. And so I wonder if it depends more on the situation, when it comes to multitasking, what the other thing you're doing is. And also in terms of like personality, again, learning styles, whether you're a visual learner or audio learner.
Yeah. And again, you've mentioned the word context, so I'm like getting a worm into your brain.
I know, absolutely, right? That's what I'm
Many,
going to be thinking.
many people who have trouble sleeping will use sound to help them sleep. White noise. I have a very dear friend of mine. He's a pathologist by background. And when he goes on long distance flights, we went once on a plane get together, and he had on these noise cancelling headsets, and I said, well, what are you going to be listening to? He said, I listen to financial podcasts. I said, financial podcasts? I didn't know you were interested in those. He says, no, not at all. They're the most boring thing in the world. And
Help them
they
go to
put me
sleep.
to yeah, the spoken word, again, it depends on the person delivering it. We've all got our favorite authors because their voice speaks to us. There are some people who are on the radio whose voices are captivating, engaging. You hang on their every word. Oh, here's the other thing. I said that we have to learn how to learn as doctors. That's what we have to learn how to learn and become dedicated to lifelong learning. It is presumptuous to think that one can just stand up and give a talk. How many talks have you been to and thought, oh my goodness gracious me, what a terrible speaker. Content was brilliant. Well, okay, here's a perfect one. There's a guy I know, he's a brilliant chap, and he'll lean into the podium and he'll say, now this next slide, this is absolutely critical. And I hope that you understand that he does that. He turns away from the microphone, points up, and then comes back and says, I hope that was just awful.
Right.
People, I tell lads and lasses who trained with me, one of the things I encouraged them to do was to be media trained.
Absolutely.
Be media trained. If you're going to do When I started doing podcasts, I did a course on, it was called Voice Talent, Voice Acting. And this very lovely American lady did a bunch of sessions with me and taught me some very useful lessons. So the first thing is, who are you? What voice do you want to be perceived as?
Right.
Who are you talking to? What emotion do you want to provoke? Not what information. What emotion? We're human beings. Engage with people. So I think that's really important. And again, the spoken word, according to my understanding of neuropsychology, requires less cognitive effort than reading.
Mm-hmm.
And that can induce a drowsy state. So good audio content, fantastic.
Yeah.
Absolutely
Quality
fantastic.
matters.
It has to be quality. Quality, not quantity.
Absolutely. Absolutely. I agree. And I think I just want to go into this last bit of the white paper where it polls physicians on how many times a day or how many times a week, a month, they listen to audio content, and 36% said that they listen to audio content multiple times daily. And multiple times daily, that's a lot. And as you say, if it's boring, if it's monotonous, it's never going to go in. It needs to be active. The tone needs to be different. There needs to be storytelling in the background for it to really go in.
Well, 100%. And there's a lot of really great content out there, and I commend GMed for getting this data out, because data will inform the quality of the content that you create. And I started using GMed because I found it a great place to come to my physician colleagues and ask contentious questions. And I love provoking, because that's when you have the best conversations. My dad, he had some wonderful expressions, and he said, people tell you not to talk about religion, sex, and politics. And he said, they're the best things to talk about, because that's when you have the really fun conversations. But would you mind if I whistle stop through just some high-level pointers that lead to good oral presentations? The first is start strong. Grab people's attention in the first 30 seconds with a provocative statement like, what do you do if your patient refuses therapy that will save their life? Stay with us. We're going to discuss that. Okay?
Touching on that, I've also heard that, shocking statistics really help in that as well. Just go off on a really controversial statistics, start on that, and then that really hooks people.
Well, I'll give you an example. I did a lay podcast all about vitamins, or vitamins as they mispronounce it here in England, vital amines. And I used a statement. I said, there's no such thing as vegans. They don't exist. That got hundreds of thousands of views. Why? Because it's provocative. Now, I'm not denying the existence of vegans, but I'm saying it's actually impossible to be a vegan. If you eat a Fig Newton biscuit, you're consuming 12 to 15 wasp heads. If you eat lettuce leaves, there's mites on them. There's bugs everywhere, right? And is it just pretty animals you don't eat, or all animals? So I was just being provocative, but it engaged people in the conversation. So be provocative. Use visuals, but keep them simple. I can't stand it when people have stuff on their slides and read it. Well, they're missing the point. Break the fourth wall, right? So the fourth wall, there's your audience beyond the fourth wall. Engage people. Engage people, engage people, engage people. Something GMed does very well. It's why it's a good platform, because it's a safe space for doctors to talk to doctors. Tell stories. Here's one for you. Get voice training, right? If you speak in a monotonous monotone, it's really very, very boring, and you're not going to keep people engaged. Inject humor and personality. Obviously, nowadays we have to be awfully careful about being politically correct. And in the old days, it was kind of a little bit more fun. But using humor is great. If you make people laugh, they're going to stay with you. Keep segments short, right? 5 to 10 minutes, and then do something to a cognitive rest stop if you want. Have takeaways, Here's news you can use. Tell people what you're going to tell them. Tell them and tell people what you told them. The length obviously matters. There's some amazing podcasts out there, but if they're an hour and 40 minutes, really, it ain't happening. Break it down into 3 segments, whatever. Slides, 6 points per slide, 6 lines per slide. That's it. These very wordy things and very wordy handouts, awful. Provide a written summary, provide a call to action, and make it germane to our lives as clinicians, right? Here's one for you. Causes of finger clubbing. I always loved that, doing that with my residents. What is finger clubbing? What causes finger clubbing? How does it happen? It's interesting, right?
I'm glad you touched upon that, because there was actually another GMed poll on finger clubbing and whether it should be used in lung cancer screening, as one of the let's say UK newspaper outlets suggested. So maybe we'll talk about that next time, because that's also a very interesting topic. But yeah, those are very important points that you made, and it's a great methodology to follow, or points to follow rather. As we said, quality in terms of audio content is very important, especially as people are going to be especially when people are multiple tasking. Multitasking, sorry. I just want to move on to the last bit now about sort of the future of audio learning in healthcare.
Right.
What do we think are, some future trends? Which direction do we think this is going? What do you say?
Well, I think what you're hinting at is AI, right? And my boring joke would be, or boring line would be, I'd like real intelligence, not artificial intelligence. Yeah, I mean, there's no two ways about it. It's already playing a role in medicine in terms of interpreting scans, treatment algorithms, identifying molecules, all that kind of stuff. I think we've got to consider how it's best used. I know it's being used to create, avatars and to do, to have AI actors, if you will, read scripts.
Yeah.
Will they do a good job? I don't know. I think one thing for sure, audio content is good. I think we're agreed on that. If it's well produced, if it's done by people who are passionate about it and really give commitment. But I think that, as far as I'm concerned, I'm much rather this, being able to see someone, because I don't know what percentages, but a high percentage of our communication is facial.
Yeah.
Micro expressions, right? Will AI be able to do that? It'll reduce the cost. I understand that, and I know that plays into the decision making. But from my perspective, the jury's still out. What do you think? And do you have any data on use of AI?
I don't. I can give you a personal example. So the other day I was asked to read a paper by somebody before getting to a meeting. And I didn't have any time to do it, truth be told. I got in the car and it was a 40-minute drive to the place. And so I found a tool that enabled me to read out. All I had to do was copy the entire thing, paste it, and then it read the whole thing out. And that's what I did in the car. And, I was prepared for the meeting. It was great. But I was thinking on the way there, because it just reads out the whole thing. What if AI could be developed in a way where we could have more of a back and forth conversation about it. If I wasn't sure on something, I could say, oh, define this, or I'm not sure about that statistic. Can you go into that? Or can you read me the reference paper for, XYZ? And I think, I don't know, I don't want to say I think that's the way that it's going, but I do hope that there is going to be more sort of back and forth. And I'm sure, with things like ChatGPT, we're already doing it visually. We're already typing the prompts back and forth. And so hopefully we'll be able to do that in the
Yeah.
audio way as well. And I think, it goes back, it's like having someone else in the car. It goes back to the idea that medicine needs to be discussed. And it can't just be passive. It can't just be one-way learning. So, this is what I hope for the future.
Yeah, it's. I was listening to. There's a podcast I do like listening to. It's an American political commentator and comedian, Bill Maher, and he had this panel and he was talking to his guests about AI friends. That there are people. Loneliness is a big issue in our cities apparently, and people are speaking to AI friends. He found it very disturbing. I must admit, I did as well. And I will share that I write articles for the aviation press on health for pilots. And I write them in a very particular style. It's my voice. And I use a lot of aviation and terminology to describe human disease and the avoidance thereof. Well, and I try to make them funny. And I tried programming an AI engine with half a dozen of my articles and then said, spit out 1,200 words on this topic. And it was factually fine, but it doesn't do humor. It doesn't do humor. And this is a literary engine. It didn't recapitulate the humorous tone. So I don't know. I never say never. I think it'll be interesting to see where this goes. I can see how it's going to reduce cost, but I know in the entertainment industry they're very nervous about it because a friend of mine who's a musician has been playing with AI and says, why is it that a particular chord or the space between two notes creates an emotional response, but if it's done by a machine, it just doesn't. It doesn't quite get it, but
it is getting better very fast. So I'm excited to see what happens in the future. It's only been around for, I don't know, it's really only blown up in the last year or two, and it's made sort of leaps of progress since. So
I'm actually an avatar, April. I'm not a real human being.
That's the ultimate twist.
Wouldn't it be? And that'd be perfect.
Absolutely.
This has been fascinating, and I think if we agree, instead of creating the content and then making an evaluation, if we commit the why we do what we do, and we do what we do so that doctors can be better educated, so they can better look after patients, because that's our mission. And let's face it, we're all going to be patients sooner or later. So if we can ensure that the education's the best quality it can be, so that people actually consume it and change their practice based upon it, then we're doing a good job.
Absolutely, that would be amazing. And so special thanks to the GMED white paper, Audio and Medicine, for today's discussion, providing us all the insights on how physicians are using audio content, how often they're using it. And we'd love to hear about how you use your audio content in clinical practice and in your downtime. And until next time.
Thank you very much.
Thank you for tuning in today. For more peer-to-peer insights and data, check out gmed.info.